and thank you for joining us for today's International Myeloma Workshop Daily Update. I'm Mary DeRome, Director of Medical Communications and Education at the Multiple Myeloma Research Foundation, and I'm here in Vienna for Day 3 of the IMW. Today, I'm joined by Dr. Faith Davis and Dr. Gareth Morgan, both from the Laura and Isaac Perlmutter Cancer Center in New York University and Langone Health in New York City. Thank you for joining us today.
Thank you for inviting us.
So today we'll talk a little bit about the sessions that we had today at the IMW, which were really interesting. And first I'd like to talk about some of the clinical data presented today that had to do with treatments for patients with newly diagnosed disease. There was one presentation on the use of 4 drugs, so a quadruplet therapy, as induction therapy. Many of our patient audience ask whether the benefits of receiving 4 drugs actually outweigh the potential risks of side effects as well as the costs because we are using more drugs. Faith, did we learn anything new today from the data presented? And quadruplet regimens are not currently a standard of care, or are they?
So I think it's quite interesting. So you're correct. There was a really lovely presentation about 4 drugs, with the 4th drug being an anti-CD38 antibody. And I think what we definitely learned was that when we use 4 drugs, we get better responses. And that in some patients, those responses can be really long-lived. And so there's some theories and some thoughts that maybe for patients who do get a great response, that they maybe don't need a transplant and can maybe just stick with those 4 drugs. One of the other important things that I think came out was that although the responses are good, there's a lot of incredibly good responses, so MRD negativity. And I think as well, when you add in that daratumumab, one of the important things was the side effect profile didn't seem to be very much different. It seemed to be very well tolerated. So I agree. I think that seems to be the way things are moving. And certainly, I think within the US, it is probably becoming standard of care to have those 4 drugs. I think for Europe, some of these clinical trials, which have been ongoing, need to be read out and be formally presented to the regulatory authorities. But I think in the next few months, year, I think we will be finding that for many patients, 4 drugs are a very good option.
Yeah. One of the things that I thought that was most interesting about that trial was once they got these patients to sustained MRD negativity, they basically stopped treating them. And then they're following them very closely over time with continued MRD assessment. And I'm really looking forward to seeing the results of this study moving forward to see what actually happens to those patients and how long they can actually stay in MRD negativity.
Yeah, no, I agree with you. There's been so much talk at this meeting about the role of MRD, and we've moved from whether we should measure it. I think there's a general feeling we should measure it, but we've also moved to, when we do measure it, what do we do with those results? And I think this is probably the first study that's being reported now that's actually saying, okay, we're going to do something with those results, we're going to act on them, and we're going to, stop therapy only in those patients, though, that have sustained MRD negativity. That's the key bit, that stopping it too soon is probably not a good idea, but that's sustained MRD negativity. And I think you're right, we're all really excited to see what happens with those patients.
Yes, and especially if we can finally move the technology forward enough to be able to assess MRD without having to take a bone marrow aspirate all the time, right? That would be really great.
Well, that was one of the other good things in a different study that got presented this morning in the science session. There was an update of the Forte study. And so that is an Italian study, which the reports, the clinical data was reported last year. But now they're also reporting some of the science that was attached to that. And they were using a peripheral blood test to look at circulating tumor DNA. And so they were having patients, they could match their PET-CT scans, their circulating tumor DNA with their response. And that's really kind of where we want to get to. And so it was really nice to see all of that data coming together. And hopefully when we with more follow-up and we see more, we'll actually be able to put that into practice as well.
Right. So really great news for newly diagnosed patients. Yeah. Also, many of our patient viewers learned that they may have higher high-risk myeloma due to the results of their FISH testing, or maybe even genomic testing. And many know that having high-risk myeloma puts them at a disadvantage for treatment outcomes, more of a disadvantage than myeloma patients who don't have any genetic high-risk features. So Gareth, are we able to know which treatments provide the best outcome for high-risk patients? For example, one of the presentations today focused on using Kyprolis or Velcade in combination with Revlimid and dexamethasone in patients with chromosome 1 abnormalities, or 1 gain or 1p deletion. So what can you tell us about how those patients fared on either one of those triplet combinations?
The best thing to do is to start off at the beginning and try to contextualize the data. So chromosome 1 is very important as a prognostic factor. Most studies have concentrated on the long arm, so that's called 1q. Other studies have concentrated on the short arm, 1p, but most data is about 1q. And it's generally thought that if you have gain of 1q, which happens in 40% of cases, that you have a poor prognosis. And some people say that 10% of patients that have amplification, so more than 3 copies of chromosome 1, have a poor outcome. And so it's very important for patients to interpret their own results in the context of that statement. So the study we heard about this morning compared 2 proteasome inhibitors, because proteasome inhibitors are thought to be good for high-risk cases. And so they compared Velcade, which is a prototypical proteasome inhibitor, with carfilzomib, a next-generation irreversible binder to the proteasome. And there's already been data that suggested that carfilzomib was better than Velcade. What we heard about today was the endurance study, which compared Velcade to carfilzomib and looked at the impact of those 2 agents on the group of patients that had either amplification or gain of chromosome 1. And in the cases with gain of chromosome 1, there was an improved outcome, but in the ultra-high-risk cases, as I would call them, the ones that have amplification, there was no difference in which proteasome inhibitor they were exposed to. I still think it's good news for patients, because if you do have chromosome 1 just gain, then I think you should think heavily about the choice of proteasome inhibitors that you use. So, interesting data, I think.
Mm-hmm. Do you know what the percentages are? You just said that there's maybe 40% of patients that have 1q gain.
Yes.
So, but is it known what percentage of patients actually go beyond that to the 1q amplification?
40% have gain of 1q, only 10% have amplification. So we also heard this morning there are some difficulties with FISH testing to define what is amplification of chromosome 1. And most things have used genomic analysis, and it's a little more accurate to use the genomic analysis. And so that says that the 10% that have AMP are the ones that do really badly.
Right. And I think that we've seen that in study after study. I mean, many different sort of therapeutic courses have been tried for these patients that have the amplification, and it just seems to really not matter. Those patients just really tend to have really poor prognosis no matter what.
So again, I hate to argue and dispute things, but I think for people out there that do have amplification, I think people can have good outcomes. It's not a death sentence having amplification of chromosome 1. The really high-risk groups are when you start to see amplification of chromosome 1, loss of p53 and loss of 17p, plus one of the adverse translocations. So that group, which is kind of thankfully small, mm-hmm. I think we really are in search of solutions for that group. Mm-hmm. But any single abnormality mm-hmm. is not so much a problem. And to justify that, we published a paper looking at AMP1Q in the absence of being ISS3, perfectly good outcome. And so it's all nuances, but I don't want to frighten people out there.
Yeah.
I was going to say, I think that's one of the things just generally for patients when they're thinking and looking at this kind of data, is that there are a lot of nuances in this. And I think we'll probably come to this later in our discussion. There was talk at this meeting about what is a high-risk patient. And all of these nuances suddenly become important because you can accidentally tell a patient that they're high risk when really they're standard risk and they should be having standard risk therapy. And I think because the nuances are important, many, I was going to say, general oncologists are maybe not aware of these changes that have come on in the last couple of years. And so, as always, it's important to kind of touch base with a specialist, I think.
Okay, so let's move on and talk about what we learned about treatment for patients with relapsed and refractory myeloma today. So yesterday, one of the main oral abstract sessions focused on some new immunotherapeutic approaches in clinical development for myeloma, treatment like CAR T therapy and bispecific antibodies. However, there are other classes of drugs that are available to patients. One drug in particular generates many questions from our patient audience, which is Pepaxto, or melflufen. Faith, can you tell us more about this drug and what today's presentation tells us about which patients might be best suited for treatment with this therapy?
So melflufen is a kind of a special kind of drug, for want of a better expression, in the fact that the way it's been designed is it's able to get into myeloma cells and then it gets activated. So outside of the myeloma cell, it doesn't work. It has to get transported into the myeloma cell and then it gets activated, and that's when it has its action. And it's not able to get back out of the cell either to cause damage. And so it's a very nice drug delivery system to be able to deliver a high dose of drug to the cell itself and not to cause any side effects. And so the clinical study that was talked about today was looking at melflufen with dexamethasone and comparing it to standard treatment, which would be pomalidomide and dexamethasone. And certainly within that clinical study, we know that there had been an improvement in progression-free survival. Okay, and they've actually gone on to try and figure out exactly which patients respond well to the drug. And interestingly, it seemed to be the older patients who had not had a previous transplant that seemed to do particularly well with the drug. And the reason I say that's interesting, because usually in all of the other studies, it tended to be the younger patients. We often find that one of the reasons why older patients haven't responded too good to drugs is because of their tolerance. And so I think it's really nice data that we have a drug where older patients can respond to it and the tolerance seems to be very good. There's clearly a few issues and, again, nuances within all of the study, and there didn't seem to be a difference in overall survival. And so that has set everybody off scratching their head to try and figure that one out. And so I think it's watch this space on that. But I thought it was certainly interesting that we now have a drug that we seem to find that older patients who have not had a transplant seem to do well with.
I'm not sure if I've seen that before.
No.
Yeah, it's quite interesting. So, Gareth, as we know, the CAR T-cell therapy Abecma is now approved for patients with relapsed refractory disease and is very effective. But as we know, their myeloma will usually relapse even after this treatment. So a lot of people in our audience want to know what can be used in patients who have already been exposed to and relapsed from CAR T therapy. There was a very interesting presentation on that today with some data that came out of Mount Sinai in New York. What can you tell us about that data and what happens to patients when they relapse after CAR T?
I think it's a really interesting question. So there was a great debate debating the role of bispecifics versus CAR Ts, and I think both sides put up a great debate, and there are pros and cons of each approach. They're being used in the relapsed setting, and of course, really, I guess, people are going to relapse afterwards, and so how are you going to manage that? I think the duration of response has been better than I expected. 11 months, survivors out 22 months, 3 years even. That's very exciting. But I think all the studies that are being designed going forward are not looking at CAR Ts on their own. CAR-Ts plus iberdomide, CAR-Ts plus Revlimid, CAR-Ts plus infusions of bispecifics, maybe. So we have a lot of ways to go going forward, which I think is good. But coming back to your question about the Mount Sinai data, I think they present data that a lot of agents are still active after you've had a CAR-T.
It was actually very good data, I thought, with the progression-free survival after that and overall survival. As he mentioned, there is life after CAR-T.
Yeah, I think it's a great way of putting it, and like being able to kind of benefit people in that setting with either novel drugs, targeted drugs like Pepaxto, alkylating agents, kind of even bispecifics. And it begs the question is, what is the mechanism of relapse after you've had a CAR-T? Is it that your immune system has given up the ghost again, and no matter whether you use any type of bispecific, the immune system doesn't work? Well, I think what that data tells you is that hypothesis is incorrect, because they are responding to both different targets and the same target again. And so it can't be the immune system that's given up the ghost. It's probably something to do with our strategies that we're using. And going forward, we have a way of really taking relapsed refractory people. I'm not saying that's the end. For CAR-T, have this, and then developing a curative strategy that you can then move forward, and it's very exciting.
Yeah. I mean, that's some of the first data that I've seen in the post-CAR-T space, right? And really just sort of laying it out, what these people, were given and how well it actually worked. And it wasn't a lot of patients, but it's really a great start, I think, to really sort of lay out that landscape of what can be done and what's going to work best post.
I thought it was really cool as well, because one of the side effects of CAR-T can be that the blood counts are really low moving forward. And that was always a concern about whether you could then go on and use other therapies. And what they did in some patients was they actually went on and gave them some of their good stem cells back that they had in the freezer, so that they could get their counts back up and then essentially reset the clock and start moving forward. So I thought that was very good.
The benefit of having stem cells stored, I think, is really good. So you can always do a stem cell transplant and kind of keep people going, reset the whole playing field and try something different. And I think that's very exciting for people in that setting.
So we're going to move on to one of the more lively and interesting sessions today at the IMW, called The Great Debates in Myeloma. So this is
Let me tell you something, like debating your wife, it's probably not where I wanted to go.
We'll get there. So this is a session where key topics in myeloma were hotly debated. So we'll just talk about what topics were covered and which side of the argument was favored. Faith, I'm going to start with you. Okay, so I mean, the first debate we had was about transplant. So should every newly diagnosed myeloma patient have a transplant?
Yeah, no, that was very interesting, because we had a vote before the speakers, and then we had a vote afterwards. And so before, everybody, most of the audience appeared to be in favour of a transplant. I think it was 70-30 off the top of my head, something like that. Was it maybe a bit higher? I can't remember. Anyway, Sergio Girault gave a really great talk about how important it was to have a transplant, but also some of the newer ways that his team are looking at to try and lower some of the side effects, which I thought was, very interesting. But then Maury Gertz was against having an upfront transplant. I thought that was a sneaky move there. So he wasn't saying that we shouldn't have transplants. I guess he was saying if you have the opportunity, you should maybe put those cells in the bank, because it's always good to have a saving account, and that maybe potentially if you need to move forward and have a transplant later, it could be an option. But with all of the new developments, you may not need to move forward and have a transplant. There may be bites. And so he quoted a lot of data about how we've been comparing patients with upfront transplants against later transplants. Right. So and so the voting kind of changed a little bit afterwards, and it kind of became a little bit more
Yeah, I need to speak there, because Rafa and his data about how many people get to second line treatment is really important in that setting. Murray didn't mention it, nor did Sergio, but only like 70 to 80% of people ever get their second line therapy. So you want to use your best treatment up front. This is a kind of modern paradigm.
Yeah, no, I have to say, in the counter arguments, that was exactly what Sergio said. Put your best foot forward, use your best treatment up front. And I think generally, although it was a fun debate, I think we all agree the best treatment may be different for different patients, but you should always figure out what the best treatment is for that patient.
And that's where the stuff about KRD and the master study and Ola's Manhattan study, that's where that data plays out. So arguably, the MRD negative rates with those treatments, with the 4-drug regimens, are higher than what we used to see after a stem cell transplant. And so if you're in MRD negative complete response, maybe you can avoid the transplant up front and defer it to later on.
Mm-hmm. Mm-hmm. Yeah, he actually was mentioning, and Maury in his argument said that transplant should be a treatment, a line of therapy, and not a platform against which everything else is placed.
So I kind of agreed with that, and yet up until now, I've never felt it, truly kind of practice changing to compare stem cell transplant versus VRD and then maintenance or transplant. So adding things into transplant have always moved us forward. Mm-hmm. But these 4-drug regimens are proving to be so effective, and the introduction of a bispecific into that background is the first time I've felt it really may be the end of autologous stem cell transplant as we know it, and especially as we start to see these signatures that the melphalan itself is driving relapse in refractory disease. So it's a changing environment.
Gareth, I'm going to go to you for the second debate, which was about MRD, right? So this is, are we ready for MRD guided therapy? And I thought it was so cute of the organizers to actually have Dr. Langone argue against this when we know that he is really one of the world's biggest proponents of MRD, testing and use of that for guiding therapy. So I thought that they made it very difficult for him.
They definitely made it very difficult for him. But much like Murray, he was smart, and he changed the question about, is it ready to go, or should we be designing trials to investigate it? And I think it was fun listening to them both. But what I think the take-home message was that achieving MRD negativity is really important. Everybody agrees about that. We should be putting it into clinical trials now and using it to help us make decisions. But in the meantime, we have to kind of do things in our clinical practice based on information. And for patients, I think information is key. The more data you have, the better the treatment decisions you can make.
Agreed. Okay, so now we come to the third debate, which again, the clever organizers pitted the two of you against each other, right?
It was a cruel and unusual punishment, let me tell you.
Talking about whether stratification of patients based on genomics, and even treatment based on genomics, is that ready for prime time, right? So, and you were the yes, and you were the no. And who was the person that won?
Well, I say that because I'm like that. Because, in some ways, I'm disappointed I won, because I actually do believe that we need to start a little bit like MRD. We need to start using it, and we need to be doing it. So, although I'm kind of obviously pleased I beat him,
she's very pleased.
The overall picture is that it shows that we have a little bit more work to do to be able to convince everybody that that's where we should be going.
I failed to fully agree with that. She gave me a to-do list, but this wasn't a to-do list that will take 3 years. This is a to-do list that can be done in the next months. There are 5 trials out there at least that are looking at high-risk disease. I think they're very important. It's a group of patients that has an extremely poor outcome currently, and we need to address it head on. And that's the plan. And again, like Ola, I think the question was subtly changed. It wasn't about should we or should we not do it. It's about what do we have to do to move things forward. And I think the audience agreed with that, what I think is a good compromise.
Okay, so Faith, back to you. The next debate was, what is the best immune approach to replace stem cell treatment, right? So we had one side was saying that CAR T could replace stem cell, and the other one was saying that bispecifics could replace CAR T.
Yeah, so in some ways I think this was maybe one of the hardest debates for the very simple reason they're both new. And nobody really knows at the moment which one is going to win. And I think most people believe that there actually isn't going to be a winner, and it's going to be very patient-specific as to which way we should go. I thought it was very interesting as well that everybody was comfortable with the fact that we would be replacing autologous transplant. That seemed to be quite a given, which I thought was quite interesting.
I'm not sure I heard that. I think I heard that both of them say that they felt that both of the modalities could enhance autologous stem cell transplant and bring about cure in the upfront setting when we get there eventually. And so I think we're both in compromise mode here. They imply both of those things, that we could do comparisons to autografting, but they both specifically made the point that maybe long term, even a CAR T on its own, with it not being persistent, may need additional modalities afterwards.
Although at the beginning, that it seemed to win handily, right? After when the results came out, in the beginning, everybody thought that the bispecifics would be the obvious choice to replace stem cell, but by the time the debate was over, it actually totally flipped over the other direction, and everyone was in favor of CAR T for that particular debate, so which was interesting. Okay, and now Gareth, back to you. The fifth debate was talking about, can we give our patients treatment-free intervals? So this goes back to the quad therapy presentation that was a little bit earlier in the day.
So I think this is a very, very difficult and very, very pertinent argument to which there is no information currently. We clearly shouldn't just do MRD testing at one time point, that's for sure. It has to be at multiple time points. Stability is important, and once MRD stability is achieved, I think you can then ask questions about, can we stop therapy? I think it's inevitable that we won't be treating good risk patients until disease progression. We have median times to progression now that are out at 7, 8, 9, even 10 years. And so that's a lot of therapy. So we have to address the question. And I think there'll be a set of clinical trials that specifically are stopping studies. You become MRD negative, you treat for a year, you treat for 2 years afterwards, and then stop. But I don't think you should be treating for 6 months, be MRD negative, and then stop, because there's at least 2 studies that show even treating MRD negative patients beyond that increases long-term survival. And so they have to be carefully designed to be doing patients benefit.
So really some more data needed there.
Clinical trials are kind of what we should do, and I guess that's the plan.
Yes, right. So, and the last debate, Faith, was about if there is a role for alkylators in myeloma.
That one was a fun one as well, because I guess the discussion, it was around our new shiny toys, and whether we still need these drugs that have been around for years and years. And then also around some, newer data suggesting that maybe they might be harmful for some patients, and they might actually accelerate the disease for some patients. But I think the general kind of overall conclusion was, you need a big toolbox, and we should have every drug in there. Yeah.
I think there's a reason to move to chemotherapy-free treatments. It's a common theme in cancer, the negative role of DNA mutating agents and their potential to, enhance progression. Like you say, it's a really, really important question. But I think in lower risk disease where you're expecting patients to live a long time, you're going to be much better off with a chemotherapy-free treatment, like analogous to CLL, where we're moving in that direction, and non-Hodgkin's lymphoma, where we're moving in that direction. And I kind of think we need to keep the progress going in myeloma and aim for the best outcomes we can.
Yes, very good point. Okay, so now we've come to the last question. So,
Oh dear.
so as but this is
a killer question.
This is actually this is the easiest question. Okay. So here, as we're ending our daily recaps for this year's IMW, so what I wanted to ask both of you are, what do you think the biggest take-home messages are for patients that are actually readily actionable for them, like right now? What have you heard at this meeting that if a patient was to step into your office and say, so I heard that you were at the IMW, what did you learn that's, applicable to my case, and what should I really know that came out of this meeting? What would you say, Gareth?
So the good thing for me is we've been thinking about it, and we changed our approach to upfront treatment recently to introduce 4-drug regimens containing daratumumab for more or less all presenting patients. And it was really reassuring for me that all the data holds up 4-drug regimens up front. If you can access them and you don't have any contraindications, it's a good way forward.
I think I would say that making sure you have all of the information would be the other thing, because I think time after time the discussion ended up around MRD or ended up around high risk, or what does this abnormality mean, what does that abnormality mean. And so I think from a patient perspective, it's persuading your doctor to do the FISH test, to do the MRD test. I think that would be really important. And even if your doctor's reply is, but I'm not going to use it, I would argue the answer is, I know you're not going to use it now, but I might need to know that information in a year or 2 years' time.
Yeah, that's a very good point. Very good point. Mm-hmm. Okay, so that concludes our session for today. On behalf of the MMRF, I'd like to thank Dr. Davis and Dr. Morgan for joining me today.
Thank you.
I'd also like to thank everyone watching, all of our updates from the IMW, and finally, I'd like to thank our sponsors, Janssen, Karyopharm, Oncopeptides, and GlaxoSmithKline. As always, if you have additional questions about what you have heard today, please don't hesitate to call our MMRF Patient Navigation Center at 888-841-6673, and our patient navigators can help you with any additional information that you might require. Thank you.